Hello, everyone, and thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a quick few housekeeping items. Next slide, please. The Private Practice Simple Solutions program is a series of rapid learning cycles designed to provide opportunities to implement actionable changes that can immediately increase efficiency. Next slide. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to carefully review this notice. And now I'd like to introduce today's speakers, Ryan Laschober and Zach Sartor, who will be taking us through this wonderful presentation on psychopharmacology. Go ahead and take it away.
Great to be here today. Thanks, y'all, for having us. We're really excited about discussing psychopharmacology. There's lots of illnesses that impact our patients' lives on a daily basis, but I think we can all agree that each and every day that when we see behavioral health illnesses in our clinic setting, that we can see the massive impact they make on lives, families, jobs, and are really excited to have you on board today to discuss psychopharmacology more. Treating behavioral health illnesses in the primary care setting is difficult. It's difficult for a multitude of reasons, but also our patients are excited for us to lean into this space more.
Yeah, absolutely, Ryan. I mean, a majority of people who seek care for behavioral health disorders do so through that primary care context. But like you said, it can be challenging for primary care clinicians to deliver care within that context. The reasons for this are really somewhat beyond primary care's control, right? There's poor specialty support services in many areas across the country. In fact, 2/3 of primary care clinicians say that they don't have any sort of specialty behavioral health service support within their practice locations. And this trend is even worse in places that are more underserved and places that are more rural. On top of that, we are primary care clinicians who are trained to treat a lot of things and maybe don't have the time and training dedicated towards behavioral health disorders specifically. And then when we look at guidelines or other literature resources, they're not written for primary care clinicians. You look at behavioral health disorder guidelines published by professional organizations, they're written for specialists, not for the primary care clinician. And so all of these things contribute to this unfortunate situation where primary care clinicians often feel unprepared, inequipped to handle a majority of what walks through the door in our practices. But I do think that there's some hope here, Ryan. I mean, just like where there's any challenge, there's an opportunity. And so this seems like no different, right? There's an opportunity here for us to deliver high quality care and really make a profound impact, like you're saying, Ryan, in patients' lives.
Absolutely. And so that's really our goal today, is to place scaffolding in place, give those who are listening today scaffolding to really succeed and thrive well when treating behavioral health disorders in the clinic setting. So let's go ahead and kick that off here.
So when we talk about scaffolding, we conceptualize this as three main pillars that support that scaffold to provide the support that primary care clinicians need in order to evaluate and treat behavioral health within the primary care setting well. The three pillars are listed here. We have measurement-based care, decision support tools specifically to support psychopharmacology prescribing, and we have team-based care, or utilizing everybody on the team to deliver that high-quality care. So Ryan and I are both academic clinicians, and so we have to frame everything with a case. It's one of our faults, but I think it's a good one, a good fault that we have. And so this is a case that is going to really highlight how these three pillars of successful, high-quality implementation of behavioral health in primary care can really come to bear. So this is Mike. This is a 42-year-old male who comes into the office for major depressive disorder. He has a past medical history of hypertension and hypothyroidism. And 2 weeks ago, you had Mike perform a routine PHQ-2 to screen for depression, and he screened positive. So this is his follow-up visit to evaluate that positive screen. At that previous visit, you did some basic labs. He had a normal CBC, normal TSH. You quickly screened for suicidality, and he denied any suicidal thoughts or ideation and agreed to come back in 2 weeks to discuss this a little bit further. So the question here is that what other tools are going to be necessary for us to evaluate the severity of Mike's depression in order to recommend a treatment plan tailored for him? This is going to open up the door to talking about that first pillar of measurement-based care.
And so when we talk about measurement-based care, there's really 3 domains to think about. These are patient-reported symptom scales. They can either be filled out by the patient individually or alongside clinical staff. They're implemented as part of your clinical encounter. They're informing what you're doing in the office today. And they really lead to an informed treatment decision between you and the patient. They can be used for a multitude of areas. They can be used for screening, gauging treatment response, and data will show that use of these tools improves the patient-clinician relationship. The real principle here is using psychometric tools to inform our treatment decisions. Just like when we're treating hypertension and we have a goal blood pressure in mind for this unique patient, or diabetes and think of a goal A1C in mind for the unique patient, we want to have those same psychometric principles to treating major depressive disorder or generalized anxiety disorder or the wide gamut of behavioral health disorders. The STAR-D trial was one of those landmark trials in the behavioral healthcare world. It's one of our first big trials that really articulated the use of antidepressants in an evidence-based fashion and really influenced lots of the guidelines around treating major depressive disorder. In the post-hoc analysis of the STAR-D trial, one of the really neat outcomes looked at comparing the success of primary care clinicians or specialty behavioral health in treating psychiatric disorders. And the post-hoc analysis really showed that when primary care clinicians used the scaffolding and psychometric tools, that their outcomes were on par with specialty behavioral health care.
So returning to our case with Mike, this is a case where we're evaluating for depression. And so we want to look at an instrument that we can use to evaluate depression. And the instrument that most of us are going to be familiar with is the PHQ-9. This is a validated psychometric instrument for adolescents and adults that can be used not only for screening, but risk stratifying depression in terms of severity, and then using iteratively over the course of treatment to assess treatment response. And we see here on the slide in the bottom left what those numbers look like. A full response being a 50% or more reduction in that PHQ-9 score, partial response being 25 to 50%, and no response being less than 25. So when we look at what other resources that we can use to treat the range of behavioral health disorders within the primary care setting, we can look at resources such as the Psychopharmacology how-to guide that the AMA has published and is free to access and use for clinicians. The resource itself includes a number of different psychometric instruments that can be used for screening and evaluation for a range of behavioral health disorders, from depression to bipolar disorder to suicidality, anxiety disorders, and obsessive compulsive disorder. So we are looking at our case here again. We're going to employ some of those measurement-based care principles to the case now. So after a thorough history and physical, you diagnose Mike with major depressive disorder. You administer a PHQ-9, which shows a score of 21, consistent with severe major depressive disorder, and you start talking to him about treatment options. Treatment options including both psychotherapy and pharmacotherapy potentially. He says that he would like to consider psychotherapy and would definitely like to start pharmacotherapy. He says that, maybe about 10 years ago, he was treated for depression. He was on a maximum dose of sertraline, was on that for a couple of months, and really didn't get much better. So via shared decision-making, you decide to prescribe Mike fluoxetine at this visit. So Ryan, I think this is a good opportunity for us to both reflect on what we've gone over so far, but then really turn our attention towards making treatment decisions, particularly with an eye on psychopharmacology, right?
Absolutely. So we've been able to apply psychometric tools to treating Mike now. And what we hear from clinicians very often is they feel comfortable with that first 1 or 2 steps in treating behavioral health illnesses. But beyond that becomes complicated. And Zach, you shared before, I mean, it can be difficult to know where to turn. There is no singular authoritative body when we talk about looking for psychopharmacology guidance in treating behavioral health disorders. And often, like you shared, these aren't written for primary care clinicians in mind. This is where decision support tools really come to play. The goal of decision support tools is to assimilate a mountain of evidence, a mountain of guidelines, a mountain of specialist guidance here, and assimilate that all into a usable tool to inform us to make impactful treatment decisions in the exam room. So using these decision support tools, we want to capture medical knowledge and specific patient data to place that through an interface engine and then get case-specific advice.
So for Mike's case then, Ryan, if we're applying this concept, we have his PHQ-9 score, which shows us that he has severe major depressive disorder. And we have some medical knowledge showing a prior failed trial to sertraline. So this decision support will take both of those pieces of information and then give us specific advice for what to do next for Mike.
Zach and I have had the joy of being editors and associate editors of the WACO Guide to Psychopharmacology in Primary Care. This has been a monumental project for many clinicians throughout the nation. It has been created by a faculty of WACO Family Medicine residency in consultation with Massachusetts General Hospital Psychiatry Academy. It's a free resource, a resource that clinicians can access that really its goal is to combine top-level evidence, expert opinion, all tailored for the primary care setting, really capturing those decision support principles that we just shared about. When you access the WACO Guide, it can be accessed through a website or through the WACO Guide app. Just searching WACO Guide, we'll find both of those. We're going to walk through the WACO Guide to really then apply treatment principles for Mike. You can click on this comprehensive tool view here and open up the wide array of diagnoses that are commonly seen in the primary care setting. I wish I could scroll down further, but really showcasing that this will capture the vast majority of DSM-5 diagnoses seen in the primary care setting. If I were to click on depressive disorder here, I can see a treatment protocol that really inform our treatment steps today. On the website, you'll see a color guide really to capture some of those high-level principles. This blue color informs treatment decisions. The orange color informs psychotherapy decisions. And then the red is that first and second choice pharmacotherapy. So we can see here guidance, and we'll apply this in a second to treating Mike. I can also click on that medications tab, and this will give dose-specific guidance, also titration schedules and max dose for that specific disorder. Additionally, you're going to see side effects, both rare and common side effects. This isn't the whole physician's desk reference. This is really those high-level side effects that we want to share with the patient in the exam room. And then lastly, if you click on that references tab, this will summarize the evidence made or the evidence. This will summarize the evidence collected to make those informed treatment decisions and a sign of strength of recommendation that this tool utilizes. So let's come back. No, go ahead.
And Ryan, I think a really important piece of this, right, is that this is free for people. So users, either end users or institutions can access this and use this via the web or iOS or Google Play Store and put this into practice and put this into action right now. No barriers, anything like that. So we're really happy to be able to share it with you.
Absolutely. And so let's apply that to Mike today then. So over the past 3 months, you've titrated Mike's fluoxetine to 80 milligrams. He's now stable on this dose for 8 weeks. He reports his symptoms have improved. However, that he shares he continues to feel symptoms of depression. His PHQ-9 has decreased to 21 to 14, indicating a partial response. You discuss further pharmacotherapy options and via shared decision-making, decide to augment his fluoxetine. We'll walk through using the app now of how we may make an informed treatment decision for Mike's care. Using the app, I can click on diagnoses and select depressive disorder here. I can then select that Mike's an adult. look to see if he has special populations. He doesn't here. I could then select his severity. Now he's mild to moderate range, and he does not currently have psychosis. Then I can select any prior pharmacotherapy trials. And so he had that trial of sertraline previously. He previously tried it. It was an unsuccessful response. And currently he's taking fluoxetine. It's his current medication, and he's now had a partial response. With those variables, I can get an informed treatment decision with first choice augmentation options of aripiprazole, bupropion, or mirtazapine. I can scroll down, click on aripiprazole for augmentation, get dosing guidance, look at side effects and monitoring parameters. Or if I were to recommend bupropion, I can see that same information there. If I wanted to scroll to the bottom and see that whole decision support tool, quickly click on that, walk through the guidance there. And then lastly, click on that references section at the bottom. And again, see the strength of recommendations towards each recommendation made in the decision support tool here. Really now allowing us to make an informed and tailored decision for treating Mike today.
And importantly, right, this is in real time. So we can get a recommendation for Mike within 60 to 90 seconds. So fast-paced, busy clinic, open the tool, get a recommendation, be able to make a really profound impact on Mike.
Well, let's take home Mike's case here. So Mike, and you decide to augment with aripiprazole. Mike asks about other treatments that could further help his depression. You think about counseling him on exercise for depression and discussing psychotherapy options, but the reality sets in. You're running 30 minutes late and behind in clinic already. So how would we think through this further?
Well, I think the first thing to acknowledge is that running 30 minutes behind in clinic, that's a great day for me. I don't know about you, Ryan, but I'll take that any day. But I do think this really, it underlies what many of us face every single day in practice, which is that it's becoming harder and harder to do everything that we need to do in practice, right? And although technology isn't quite to the level of me being able to clone myself so that I can see both of those patients who've been waiting for 30, 45 minutes at once, maybe it will be there one day, but we're just not there yet. So we have to find other ways that we can effectively evaluate and treat folks in a way that really utilizes everyone's strengths within that clinical context. And so we've talked about measurement-based care, using data in a way that informs treatment. We've talked about taking that data and applying decision support tools in order to arrive at evidence-based treatment recommendations for psychopharmacology. Now we're going to talk about how we utilize everybody on the team in that clinical setting to deliver high-quality care. Again, just to drive this point home, because I think that most of us feel this, but it's always validating to have a study that says, oh, absolutely, this is my life, this is my experience. There was a study published this year in the Journal of General Internal Medicine that showed that the average amount of time that a primary care provider needs to do everything that we're tasked with doing is something like 26.7 hours. And Ryan, the clocks that I have in my house, there's only 24 hours in a day. And so something's got to give here, right? And ultimately, what we're talking about is developing team structures and team-based care that will both serve as a steward of the physician's time, but then let other people on the team practice to the top of their license in order to achieve that ultimate goal of delivering high-quality care for patients. So what are some of these examples of things within the behavioral health realm that other members of the team can provide in terms of brief intervention? So going back to our case, Mike is doing pretty well. Augmentation with aripiprazole is going well, but he's asking, hey, are there other things that I can do to help myself? And we know things like exercise or other non-pharmacologic treatments can be really effective for depression. And if you had 30 minutes to talk to Mike about all those things, I think that would be great. But one thing that you can do instead is have some templated or structured brief interventions that other members of your team can provide Mike. And this is just an example of what some of those things look like for behavioral health disorders across the spectrum in adolescents, adults, and children. So we see things like brief CBT or problem-solving therapy for depression or anxiety disorders, things like supportive counseling or supportive psychotherapy for grief. Psychoeducation is, of course, really important, especially for serious mental illness like psychosis, and can be something that can be implemented very well within that primary care structure. Brief advice, brief interventions for substance use like opioid use disorder or tobacco cessation can also be equally effective. So I think this gives us an idea of there are other things beyond psychopharmacology that we can use within that primary care setting and really rely on the team in order to enact those. And knowing that if we focus our psychopharmacology prescribing to the best of our ability and implement a lot of these other brief behavioral interventions, the synergy between those two is going to lead to even better outcomes for patients. So one way to make this work, I think, really well for us in clinical practice is by utilizing a huddle. So practical, easily implemented huddle ideas. And there's some resources available through the AMA Steps Forward program that you can claim CME credit for to talk about how team huddles can actually boost your productivity and then ultimately save you time in the long run. So I think an example of this, Ryan, would be, maybe for Mike's next appointment, you have a huddle at the beginning of the day. You identify Mike on the schedule. The nurse or MA or somebody else on the team has already administered a PHQ-9 to follow up on Mike's progress up until this point. You go in, see Mike, you identify an area of need for non-pharmacologic intervention. You have a behavioral health provider or some other team member come back in and do brief interventions and psychoeducation or whatever else Mike might need. And so that huddle can really facilitate that process and make it run, hopefully, smoothly and ultimately save us time. Again, we want to highlight that the Behavioral Health Integration Compendium and the how-to guides have some excellent resources in order to help you identify who on your team can do what. And so who on your team can be responsible for evaluation and screening, who can be responsible for counseling and education. And it lets you take an inventory of your team members and then assign potential roles for those team members so that you can have everyone utilize their strengths and practice to the top of their license. So really want to highlight that. Really great resources that can take you from conception to implementation of team-based care workflows.
This is a wonderful resource. And I think one thing we can all realize is when you've seen one practice, you've seen one practice. This resource gives you a framework to then think through of how you may tailor some of those workflows for your unique practice setting.
All right. Well, we've talked through measurement-based care, and we've seen what that looks like in informing our treatment decisions for the case of Mike. We've looked at decision support and how resources like the WACO guide can be used to get evidence-based, reliable, and quick recommendations that complement your medical decision-making and enable you to achieve high-quality prescribing for psychotropic medications. And then we've looked at how the team can be used to effectively treat patients like Mike and ultimately provide some stewardship for your most valuable resource and commodity, which is time. So just to wrap up the case here with Mike, he comes back in 4 weeks later and his PHQ-9 score is a 6 now. He says that he's exercising and practicing the brief CBT techniques that he cultivated with your behavioral health provider at his last appointment. He's feeling great, functioning well, and he feels that he's well on his way toward thriving. So Ryan, just summarizing everything that we've talked about so far, right? We started with the challenges and the barriers to effectively treating behavioral health disorders within that primary care context. But just like any challenge, it can be seen as an opportunity. And so our thoughts are that with these three important components of measurement-based care, decision support, and utilizing the team via team-based care, we can rise to that occasion, meet this challenge head on, and really change the trajectory of some lives and really provide high quality behavioral health care within that primary care context.
All right, and that concludes our presentation for today. Thank you to both our speakers for sharing their time with us. We encourage you to check out this attendee chat that's going to be on the left-hand side of the screen, so you can connect with your peers, Dr. Laschober and Sartor. They'll be checking to reply for any of your questions or comments on Wednesdays on 1. Next slide, please. And we have additional resources and frequently asked questions available on our website at stepsforward.org. Thank you, everyone. Have a great day.